Good morning, everybody. What a strange way to talk to you. Normally, we would have been in beautiful, sunny Thessaloniki having our first plenary session of the ERS, also about EPOS. We all know why that's not possible, but I would like to think one moment with all of you, especially thank Yanis Konstantinidis and his team for all the work they did. And I sincerely hope to see all of you in May 8 to 11 next year in Thessaloniki to have a fantastic ERS meeting. But now we're going to talk about EPOS 2020, and I would like to start introducing Professor Valerie Lund. She doesn't really need introduction, of course, but still, I would like to introduce her. She has been professor in otolaryngology in London, and we worked on EPOS together for 15 years now, I think. And Valerie, thank you very much for going into this adventure together. We spent a lot of hours talking to each other in the last year to get EPOS to what it is now. And I would like to thank you for that. I would like to introduce Professor Lund's presentation from Bench to Bedside about EPOS.
So thank you very much for asking me to talk about EPOS 2020, and also to thank you all for joining me during what can only be described as unusual and difficult times. Some of you listening to this may actually be too young to remember the first EPOS, which we brought out in 2005. It was the first evidence-based position paper looking at rhinosinusitis. At that time, there were only 650 references. And so in a couple of years, we produced another one, 2007, when the evidence base had gone up to over 1,100 or so references. And I think one of the big successes of EPOS has been to highlight the gaps in our knowledge, which we hope research provoked by and precipitated by EPOS will have filled. Then we came to EPOS 2012, and of course there's been quite a gap between that edition and the present one, which came out in February. And several people have asked us why we didn't produce something a bit sooner, but we knew that there was a lot of work going on, looking new research on the pathophysiology, on different concepts of medication, and in particular, quite a lot of new treatments, as well as changes in our surgical philosophy. So we wanted to try and capture that in the new edition. This is very easy to get hold of. It's available free of charge as a free download from the Rhinology website. The full document is a supplement with over 460 pages, and there is also an executive summary which came out in the journal at the same time. So both are easily available to anybody who would like to have it. We've called it a European position paper, but in fact it's extremely international because we have a steering group of 47 people from a whole range of different specialties and from different countries. And that includes not just ENT, rhinologists, but basic scientists, chest physicians, allergists, pediatricians, general practitioners, pharmacists, nurses, and most importantly, patients. We also got the document reviewed by another 104 experts, and so overall 69 countries are represented in the document, which cover virtually all continents. So what's new in EPOS? Well, obviously we've updated across the board all the various aspects of rhinosinusitis, and we've expanded on many of the existing sections. Classification, definitions, and terminology are important and have been looked at again in some detail. And as I said, the concepts of pathophysiology have changed considerably in the last 8 years. We've looked at the concepts of control versus cure, and completely revised and expanded the section on paediatric care. I've said that concepts of surgery are changing, and this is something which has been given a lot of interest in the document, and you'll hear from Professor Bockens about integrated care pathways. And at the end of the document, we've put together a list based on the contents of areas where research is really important to be done in the future. So in this talk, I'm going to concentrate on these particular areas and hopefully try to give you an overview. When we put together the new document, we used a framework based on Agree2, which is very important to ensure consistency, transparency, and aspects such as editorial independence. We used a mixed methodologies. That means the majority of the contents are based on evidence, systematic reviews, and meta-analyses. But of course, there are areas where no evidence is available. And then we instituted Delphi processes amongst our steering group. We started off with 30,000 references, which were mainly randomized controlled trials and systematic reviews, which were provided by a medical information expert. And then Professor Fockens and I and some other colleagues went through all of these and reduced it down to just over 3,500. It's important to know that only published literature has been accepted in EPOS 2020. And that may lead in the future to more detailed revisions and updates on particular areas, because things will be changing in the future at a fairly rapid rate. We did the whole thing pretty much electronically, but we did have 3 face-to-face meetings of the full steering group in various parts. Now, what about the definitions? Well, we've been using the term rhinosinusitis since the 1990s. And the reason for that is that it was recognized fairly early on that it was difficult to distinguish between where rhinitis stopped and sinusitis started. They coexist, and they're difficult to distinguish either physiologically or pathophysiologically. And this terminology has by and large been widely accepted. If we look at how this can be approached in primary care, it's certainly possible on the basis of symptoms for general practitioners to distinguish between rhinosinusitis and allergic rhinitis. In secondary care, ENT surgeons have more than symptoms at their disposal. They can look in the nose with an endoscope or perform imaging, and they will be able to distinguish different phenotypes of rhinosinusitis. And then perhaps in tertiary care, we look to the specialist rhinologist to help break down rhinosinusitis into its many component endotypes. However, when it comes to a broad definition of rhinosinusitis, that really hasn't changed. After all, it is only inflammation of the nose and paranasal sinuses. And that applies to both acute and chronic, whether there are polyps or not polyps, etc. The nose and sinuses, when they're inflamed, only have a sort of limited repertoire for which the symptoms occur, and therefore the 2 main symptoms of rhinosinusitis are blockage, congestion, obstruction, and the presence of discharge, be it anterior or posterior. This may be accompanied by reduction or loss of sense of smell, particularly in adults, and or facial pain or pressure. However, we recognize in children that the loss of smell may not be something that they are particularly aware of or complain of, and in studies looking at symptomatology for children, cough, both day and night time, is one of the main cardinal symptoms. We still have to rely on a fairly basic duration definition for these conditions, and this is because of the regulatory authorities. So there is a break point at 12 weeks, which is somewhat arbitrary, and therefore acute is a condition which starts suddenly and completely resolves and lasts for less than 12 weeks, whereas in the chronic situation, the symptoms go on longer than 12 weeks and there is no complete resolution of the symptoms. We can try and stratify the disease by severity, and this can be easily done using a visual analog score into mild, moderate, or severe. It's also possible to do this using a SNOT-22 score. When we look at the definition of acute rhinosinusitis, both in EPOS 2012 and in the new document, we recognize that there are effectively 3 areas of rhinosinusitis that we have to consider. Clearly, the common cold is the commonest and most basic form of acute rhinosinusitis, a viral infection. But we also have a group of patients who continue to have symptoms for longer than 10 days, or indeed their symptoms start to increase after 5 days. And we have used the term post-viral acute rhinosinusitis to cover this condition. A proportion of them will go on to have the signs and symptoms of a bacterial infection. These will include a fever, presence of a predominant side, severe pain, and possibly markers of inflammation if they're done. So this allows us to stratify the condition both in terms of its physiology and pathophysiology, and also in terms of its treatment. Now, in rhinosinusitis, we also have the option of being able to consider our patients with our objective measures, such as an endoscope, to look for signs of discharge or swelling, and or the use of imaging, be it a CT scan. Though it's worth adding a caveat here that if we have a CT scan which shows only minimal thickening involving only one or two walls of the sinuses and not the osteomiatal area, it's unlikely to represent rhinosinusitis. We've also added in other clinical definitions. We recognise that acute rhinosinusitis can occur more than once during a year. And so recurrent acute rhinosinusitis is defined as 4 or more episodes per year with symptom-free intervals. In an ideal world, we'd like at least one of those episodes to be confirmed with endoscopy and or imaging. And we also defined acute exacerbations of chronic rhinosinusitis, where against a background of chronic rhinosinusitis symptoms, we have an exacerbation, a worsening of symptoms, which then return back to the previous baseline. There have been quite a few studies looking at the prevalence of the cardinal symptoms of CRS. And you see in this figure taken from EPOS that the areas have been looked at in primary care, amongst a general population, in outpatient clinics, and in those patients undergoing surgery. In all of those circumstances, nasal obstruction is still the commonest symptom. But there are some differences, particularly with respect to changes in the sense of smell, which are particularly notable in patients who are undergoing surgery and those who have nasal discharge and facial pain. So it does very much depend on which patient group and which environments you are dealing with as to which of the symptoms will be the most prevalent for the patients. We also can look at the severity of the cardinal symptoms here. Again, there's a little bit of variation between the patients in the outpatient setting and those undergoing surgery, but by and large, the nasal obstruction still remains one of the most important symptoms. We move on to the epidemiology of these conditions. In the globality of acute rhinosinusitis, we know for sure that the common cold is the commonest condition. And being a viral condition, we recognize that between 2 to 5 episodes a year are experienced by most adults. In school children, of course, it's somewhat higher, 7 to 10 episodes per year. If we combine the post-viral and acute bacterial rhinosinusitis, at least one study from the Netherlands shows that about 18% of ARS is constituted by these conditions, with a range of between 17 and 21%. So overall, it's a very small number that actually go on to have acute bacterial rhinosinusitis, and this is really important when we come to talk about treatments. Only 0.5 to 2% in the studies. Now, there's a very long list, of course, for predisposing factors for a true acute bacterial rhinosinusitis. We can readily think about dental causes and also iatrogenic problems related to previous surgery, packing, and in the intensive care setting, the use of nasogastric tubes or mechanical ventilation. Immunodeficiency in its many forms can also predispose to acute bacterial infection, and it's noteworthy to see that smoking also comes into this list. Mechanical obstruction, things like severe deviation of the nasal septum and a concha bullosa, have been shown to increase your risk, as well as other structural changes relating to the presence of polyps, tumours, foreign bodies, and even the crusting associated with vasculitis. And then we have more generic mucosal edema associated with things such as allergic rhinitis. When we look at the epidemiology of CRS, again, there's quite a broad range of prevalence quoted in the literature based on symptoms. The range is 5.5 to 28%, and you can see here the countries represented by their percentages from 5.5% in Brazil right the way up to 28% in Iran. However, if we then add in endoscopy and or imaging to validate the symptoms, the number of CRS cases goes down quite significantly to 3 to 6%. One of the biggest epidemiology studies on this topic was done through the Galen Association, looking at adults between 15 to 75 years from 19 European centres in 12 countries. And over 57,000 patients were included in this large study. But again, it showed quite a range between the different countries, just under 7% for Finland, up to 27% for Portugal. This slide shows a map of Europe and the countries involved in the study, where you can see there's quite a marked difference between different parts of the countries. Again, when we look at predisposing factors, in this case for chronic rhinosinusitis, we see a very wide range of problems. Again, smoking features, as well as intrinsic problems, inherited problems, and other comorbidities. It's a really wide, heterogeneous group of things that can predispose you to getting this condition. And each of these areas is dealt with in some detail in EPOS. When it comes to looking at the burden of acute rhinosinusitis, there are a number of studies looking at this, though rather less than has been done in chronic rhinosinusitis. There are two questionnaires, the measurement of acute rhinosinusitis and a modified SNOT questionnaire, the SNOT 16, which has been validated for the acute condition, both of which show that quality of life is impacted quite significantly by the disease. However, if you use an SF36, a generic quality of life measurement, then the impact is less than it is with CRS. This, of course, brings us on to the direct medical costs of these conditions. And certainly in acute bacterial rhinosinusitis, being an extremely common condition, we see considerable costs associated. It's been estimated that there may be 20 million cases of this condition a year, and of those, 1 in 3,000 adults suffer from recurrent attacks of the condition. Looking at an average of 5.6 outpatients and 9.4 prescriptions, in America it was estimated that recurrent acute rhinosinusitis costs over $1,000 US per year. CRS has been shown to have an even higher burden than acute rhinosinusitis, obviously because of its length of time. And indeed, there are some very early studies done in the 1990s showing that the impact on quality of life was greater than for a number of other chronic conditions, including angina, various chronic lung diseases, and even things like insulin-dependent diabetes. If we use a common quality of life questionnaire, the SNOT 22, we can show that for controls, the mean score is 9.3, whereas with CRS, it is 42. And in fact, that score is higher in patients who don't have polyps than those that do. This again translates into high medical costs for the condition. Again, in the US, the cost has been estimated to be something in the region of $2,600 overall, between $10 and $13 billion a year. And similar costs have been estimated in Europe, around 2,500 euros. It's interesting because a lot of the treatments range in cost, particularly surgery. If you compare the cost of an endoscopic procedure in the States, averages at about $11,000, whereas in India, it costs $1,100. But nonetheless, it means that there are very significant costs wherever you go in the world. And healthcare spending is, as we've said, greater in CRS than other chronic conditions, such as asthma and hay fever. And once again, the indirect costs are substantial. In fact, they account for 40% of the total costs of rhinosinusitis. So it becomes one of the top 10 most costly health conditions for US employers. And we're not just talking about time missed from work, which averages between 4.8 and 5.7 a year, but presentism, where people go to work but don't perform to their full capacity, which can lead to a 38% decrease in work productivity. So we're talking about massive amounts of money at stake here. In EPOS, we've also looked in detail at the relationship between the upper and the lower respiratory tracts. The one united or global airway concept has been with us for some time, and it's a really important one when you're dealing with patients who come with problems in the upper respiratory tract, to recognize that this is part of an overall disease. And indeed, they may have problems in the lower respiratory tract, which have hitherto been missed. It's also important because we know that many of our concepts, phenotyping, endotyping, and indeed many of our treatments have actually come from our colleagues in pulmonary medicine. Back in the day, we used to think about CRS in very simplistic terms, dividing it in a binary way into those with polyps and those without. And a lot of the literature still reflects that. However, we realize that this is a very much more complicated situation, and we really have to think of it as more of a spectrum or a combination of conditions and physiological, pathophysiological pathways. I'm grateful to Professor Falkens for this slide, which again emphasizes the different types of disease that may be present when we talk about rhinosinusitis. And if we look at the Galen cluster analysis of the patients, we can see that whilst they broadly break down into T1 IL-5 negative and T2 IL-5 positive, within particularly the T2 group, we have a vast number of endotypes constituting this overall group. So there is considerable heterogeneity in the patient's problems that we treat. And what I've mentioned so far is very much a Western worldview. We think of our patients with nasal polyps being predominantly eosinophilic, but we know that in other parts of the world, particularly in the Far East, that this eosinophil predominance is not always found. And indeed, there have been a number of studies showing that there is more neutrophil or mixed picture found in some of the countries that I've listed below. What's even more intriguing is that there are some very nice sequential studies showing that there's a change occurring in this predominance of eosinophils with time as the Far Eastern polyps come to more resemble the ones we see in the West. Now, I know that Professor Kern is going to be talking in some detail about the pathogenesis of CRS, but this diagram, which appears in EPOS, very nicely encapsulates the problem. We know that there are a multitude of known and unknown factors found within the environment and within the individual host, which constitute the various endotypes or molecular pathways. Research has shown us that the mucosal barrier is very important in this situation, and if it is breached, the body mounts a response which is both cellular and cytokine, in which the various classes of pathogen are targeted, be they viruses, parasites, bacteria, or fungi. And if things are going well, those pathogens will be eliminated and barrier integrity will be restored. However, in chronic rhinosinusitis, the chronic inflammation doesn't resolve. We still are utilizing those pathways, be they T1, 2, 3, or a combination thereof. But this in turn will lead to changes, remodeling with goblet hyperplasia. And in the case of a T2 predominant response, we will see cytokine release, IL-4, 5, IL-13, activation and recruitment of eosinophils and mast cells, and changes that we're all familiar with, such as polyp formation and changes in the epithelial barrier permeability. One of the things that we wanted to get away from in the new EPOS was this binary difference between CRS based on with and without nasal polyps. And to this end, we have created a new classification, dividing it into primary and secondary. You can see in this slide showing the primary CRS that we've then subdivided it by anatomic distribution into localized, largely unilateral, or diffuse, where both sides of the sinuses are involved. Then we've looked at endotype dominance, be it type 2 or non-type 2, and based on that we have examples of phenotypes which you see in the far column, be it allergic fungal rhinosinusitis or an isolated sinusitis such as in the sphenoid or maxilla. And for the diffuse we see for the non-type 2 CRS, eosinophilic or with polyps, allergic fungal rhinosinusitis or central compartment allergic disease, and for the non-type 2, the non-eosinophilic CRS. You may say, well, what's eosinophilic CRS? Well, we've tried to define that based on histology, looking at the number of eosinophils per high-powered field. In the literature, the criteria range from 8 to 12, so we've gone for 10 per high-powered field as the criteria to make that distinction. We also had long discussions about allergic fungal rhinosinusitis versus eosinophilic fungal rhinosinusitis, but in the end we came down to using AFRS simply because it's commonly used. However, we recognize that of course not all cases are truly due to allergies to fungi. And CCAD, if you're not familiar with it, is a variant of CRS with polypoid changes in the entire central sinonasal compartment, whilst the rest of the surrounding sinus mucosa remains relatively normal, a so-called black halo, which is likely due to allergy. If we move on to secondary CRS, again, we have the same anatomic distribution, but here the endotype dominance is determined by the pathology, be it local or more systemic. For examples of phenotypes, we have dental, fungus, and of course things like tumor. But for the diffuse, we have broadly mechanical, where in primary ciliary dyskinesia or cystic fibrosis, it is a sticky mucus problem. Inflammatory, broadly defined here by vasculitis, and of course the various selective immunodeficiencies for immunity problems. Now, another area that we were keen to look at in some detail was those patients who simply don't get better, the difficult to treat or recalcitrant patient with rhinosinusitis, patients who have persistent symptoms despite appropriate treatment. And so they are not achieving an acceptable level of control despite what we would regard as that appropriate treatment. And we know it's actually quite common. We see recurrence of disease after surgery as high as 60% of patients, half of these patients of whom have had previous surgery. So the primary goal of any of our treatments, especially in chronic disease, is to achieve and maintain clinical control. And that is a state in which the patient doesn't have symptoms or has symptoms which are not impacting their quality of life. However, we used this concept in the previous EPOS in 2012, and subsequent validation studies suggested that it may overestimate the number of patients who are uncontrolled. So looking at that in some detail, a mean visual analog score of 5.5 seemed to be the break point if you looked at total nasal symptoms for whether or not patients were bothered by their symptoms or not. And we've encapsulated that in the latest version of our control. And here is the table. And I think it's quite an important one. We've divided up patients into controlled, partly controlled, or uncontrolled, as you see here. And we've used a range of cardinal symptoms: blockage, discharge, pain, and smell, together with a more general quality of life issue, sleep disturbance or fatigue, and then, if it's available, nasal endoscopy, plus the need for rescue medication. And using this in a very general sense, or for research purposes using a visual analog score, we can actually determine whether a patient is controlled, partly controlled, or uncontrolled. Now, there are many reasons why patients may lack control, and this diagram just covers the obvious categories. It can be diagnosis related, treatment, patient, or disease related. And these, again, are covered in considerable detail in the document. There are, of course, many conditions which can lead to an incorrect diagnosis. We know that allergic and non-allergic rhinitis can be mistaken for chronic rhinosinusitis. There is a very long list of conditions associated with olfactory loss, as we know only too well from our experiences with COVID. And there is a massive differential diagnosis of facial pain. And all of these things are covered in some detail in the document. We also know that there are a long list of concomitant diseases or systemic problems that can confuse the issue when we're dealing with patients with CRS. And again, each of these have their own full section in the document. The diagnostic and objective assessments available in CRS are quite extensive, and this list here shows the ones that we have discussed in some detail in the document. We've also put them in a list and stratified them according to their utility in the various levels of care. In primary care, GP has at their disposal a history of symptoms and a general examination. In secondary care, of course, we have endoscopy and the application of things like quality of life assessments, as well as the possibility of doing allergy testing and arranging for imaging. And then perhaps as we merge into tertiary care, we have available to us a range of more sophisticated tests, which will allow us to look at the endotypes that we're dealing with. It's actually difficult in the literature to find randomized controlled trials in order to do any sort of systematic review for the diagnostic testing. They're simply not there. And so this is where we particularly use the Delphi process to try and get some handle on what we thought was the right recommendation. We looked at quality of life in ARS and CRS and asked what was the use of this? Did people generally use them at first meeting the patient or subsequently, and which test did they use? And then we moved on to look at the other tests, including CT and other diagnostic testing. In fact, interestingly, the only Delphi process where everyone agreed 100% was that a quality of life instrument was important for the management of chronic rhinosinusitis. But I can tell you that we certainly couldn't get everybody to agree which was the best one to use. And here you see an example of the Delphi test for CT scanning. The first shows in the pie diagram that Delphi, for a CT being essential after failure of appropriate medical or surgical therapy in a patient who had continued symptoms with abnormal endoscopy, was thought to be generally important. 91% of the respondents said this was something that had to be done. But if you had a patient who came in the same situation who needed treatment but had an old scan, was it legitimate to use that old scan? In fact, we asked them if the scan had been performed in the last 6 to 12 months, could they still use that scan? And you can see from the pie diagram that the response was overall unclear. However, if the scan had been done 3 years ago, then most people agreed that that would not be acceptable and further imaging would be necessary. So these processes are useful to get an idea of general recommendations, but of course, we can't easily do a proper randomized controlled trial to prove it. And I think if we go back to that list, we can see that here we have the areas where, for the future, it will be increasingly important, particularly when we're trying to determine the endotype of our patients to decide which of the various treatments are the most appropriate, we can actually concentrate. Nasal smears, swabs and biopsies, looking for the various markers, and similarly looking at serum for the same sort of things. Because the most important thing really for the future is to find a reliable, simple and cheap biomarker, because on this hangs our best bet to implement precision medicine. We will hear later on about the various treatments available to us and the evidence that supports their use. But it's really important that we can translate that research, the literature, and our knowledge of evidence base into tailoring our treatment for patients, really to give them the best opportunity to improve and for us to get control of their disease. Thank you very much. Hello, everybody. Thank you very much for bothering to spend the time this morning to come to this session, and thank you for listening to the first presentation, which I do for you. We've received some questions, and what we were asked was that in the classification, there was no mention of antracranial polyp. Clearly, in a talk like this, we have to reduce things down to their sort of most precise and sort of concise as possible. And indeed, you're absolutely right that in the slide I showed you, antracranial polyp was not actually mentioned in the classification, but clearly it would it be included in the secondary local pathology together with tumour and other localized pathologies. So it's there, but unfortunately I didn't actually mention it in the talk. Another viewer has asked, in primary CRS in the diffuse forms, is it possible to include CRS with nasal polyp in terms of non-eosinophilic CRS? And it's an excellent question, and indeed it's one of the things that we really wanted to encompass in this definition. And perhaps our mistake is actually having the word CRS with nasal polyps actually featuring in that classification at all. Because really what we are trying to do is make this distinction between the predominantly T2 eosinophilic disease and that which isn't. And we did that on the basis, as I mentioned, of the number of eosinophils per high-powered field. And therefore,
you're absolutely right. It would be quite possible to have a patient who has polyps, but because the level of eosinophilic infiltration is low, they would be included in the non-eosinophilic CRS. Another question has come in asking about the terminology and why we haven't used the term subacute sinusitis. It's an interesting question because certainly when I was training, subacute sinusitis was an entity that was discussed. And you do find it, particularly in the American literature. But from the outset in EPOS, we always felt that it was a rather confusing term and one that was sort of difficult to actually define, particularly if you take a break point of 12 weeks between acute and chronic. And so we simply have not used it as a term in the document, either in 2005 up to the present day. Somebody's raised an issue regarding our title, European paper. I think I mentioned at the beginning that, of course, we call it European, but if you look at the composition of the steering group, then, of course, it covers a very much wider group of people from outside of Europe. And also, when we sent the document to review, we tried to engage with every country that we possibly had contacts with who might have association with their own ENT or rhinology societies to get their feedback. So we very much tried to make this as inclusive as anybody and everybody throughout the world in order to get their input. And we're also, as before, going to have the document translated into a number of languages, which will make it more accessible to a large number of people around the world. And we've tried, I think, with some success, to recognize within the document that there are differences between healthcare delivery around the world, and that simply for all sorts of logistical and cost reasons, not all treatments are going to be things that can be used by everybody. Somebody's asked, will there be another 8 years before we could have the next edition of EPOS? We're getting a bit older and grayer by then. But having said that, we are very conscious of that interval. And we know that change is gathering apace, particularly in research in the treatments of treatment for for CRS. And what we would like to do, really following the model from ARIA and other documents, is trying to bring up regular updates, which recognize that perhaps in the next 6 months or year, there will be a number of new publications, perhaps in the area of the biologics and in other areas too. And so we will try and produce updates to appear in Rhinology, and these will allow us to continually bring the document up to date. And there were some Delphi processes used in this particular version of EPOS. Clearly, we only use them mainly for the diagnostic areas on this occasion, but it's certainly Professor Focken's contention that this will be a rolling program and that there will be lots of other areas that will be looked at in the same way if we don't have the hard, high-value evidence to support it. I've got a nice complimentary comment from one of the viewers. Thank you for that, saying that we've done a lot of work and that it's been valuable, and it's very nice to hear that. It has been a lot of work, but I think we would both agree that it has really been worth it, and we've enjoyed doing it, although there were moments, but overall it's something that we're very happy to have been part of. So I think we're coming to the end of the QA session. So what we would like to do now is to move on to my very good colleague, Professor Fockens. Remember that during her presentation, continue to upload any questions that come to you. And if you want to add your name or where you come from in terms of the country, etc., that would be helpful, but it's not necessary at all. We'd be very pleased to hear from you. Really, it is my very great pleasure to introduce Professor Fockens, who, as you all know, is working in the Netherlands at the Amsterdam Medical Center. She has been the principal architect and force, and I can say that, force behind the EPOS project for, goodness, since its inception in 2004, so 16 years. It's just flown by. She's also General Secretary of the RS, and the chief editor, of course, of Rhinology and the new Rhinology Online. And so nobody is better placed, really, to give us her insights into the EPOS management of patients, and in particular, looking at what's new in terms of the overall and integrated care pathways. Over to you, Wietske.
Hello, everybody. I'm very happy that you look at this webinar organized by Euphoria, ERS, and EPOS 2020, EPOS 2020 from bench to bedside, and following the lecture of Professor Valerie Lund, I would like now to discuss with you the management of our patients and what is new in EPOS 2020. We want to discuss integrated care pathways for acute rhinosinusitis, a little bit again on the classification on chronic rhinosinusitis, although I know that Professor Lund already discussed that quite extensively, evidence-based treatment, and the new integrated care pathways in chronic rhinosinusitis. If we look at the definition of acute rhinosinusitis, it's important to realize that a common cold is a viral acute rhinosinusitis. But you can see at the cartoon here on the right that many patients actually have symptoms lasting longer than a week, especially cough, nasal obstruction, and nasal discharge are often there longer than a week. These symptomatology, this phenomenon we call post-viral acute rhinosinusitis. And it's important to realize that these symptoms, this disease is not caused by bacteria. Only when there are at least 3 of high fever, double sickening, unilateral disease, severe pain, or raised ASR or CRP, we call it acute bacterial rhinosinusitis. And I come in the management to why that is very important. And if you see the little cartoon here on the top right, you see here a dot which depicts acute bacterial rhinosinusitis, and an even smaller dot depicting acute bacterial rhinosinusitis needing antibiotics. And both these dots are probably still 10 times bigger than they should be if we look at prevalences, but that's the smallest we could draw that you could still see. So if we look now at the evidence for the treatment of acute bacterial rhinosinusitis, and in EPOS, we try to describe all the evidence available, and whenever possible to make meta-analysis of the available evidence. And here you see a forest plot meta-analysis of the studies done with antibiotics versus placebo in patients with acute bacterial rhinosinusitis. And the first cartoon shows the cure at a week, around a week. And you can see in this selection of patients with acute bacterial rhinosinusitis, there is a significant effect of antibiotics. It favors antibiotics. And the same, the cartoon on the lower part, where we looked at improvement of symptoms 3 days after starting treatment. Again, the forest plot favors antibiotics. So for acute bacterial rhinosinusitis, antibiotics can be helpful, which doesn't mean it has to be given to all patients, only when it is really needed. However, if we now look at post-viral acute rhinosinusitis, and again, the same forest plots depicting all the studies done with antibiotics in patients with post-viral acute rhinosinusitis, so patients having symptoms for more than a week, or more than 5 days, and having an increase of their symptoms, you now can see that actually the little square here does reach the line. And that means that there is no significant difference between treating with antibiotics or placebo. And actually, if you want to depict the very small advantage of giving antibiotics, which is 6%, 106, so 6%, it would mean that we have to treat 17 patients to make one a little bit better. And it doesn't matter whether we look at cure, like in this top graph, cure at 10 to 14 days, or whether we look at the number of days that the patients are ill, or at the improvement at day 3. For all you see the same. There is no significant difference between giving antibiotics and not giving antibiotics. So this is a clear indication why it's so important to differentiate patients with post-viral acute rhinosinusitis from bacterial rhinosinusitis. So use these 5 criteria to differentiate the patients and do not give antibiotic to the post-viral acute rhinosinusitis. If you want to give a treatment, you could consider giving an intranasal corticosteroid. And here you see the studies done with an intranasal corticosteroid in post-viral rhinosinusitis. And you see here that there is a significant effect of corticosteroids. So if you want to give treatment in post-viral rhinosinusitis, you can choose to give an intranasal corticosteroid. Why again is it so important not to use antibiotics? Well, I'm sure you're all aware of these sort of cartoons describing the amount of microbial resistance in Europe. And on the left of this cartoon, you see the consumption of antibiotics for systemic use in the community in Europe, and on the right, the amount of resistance for a macrolide, for a streptococcus. And as you can see, these two significantly overlap. In the countries where there is a high consumption of antibiotics, there is a high resistance, and vice versa. So if we all stop using antibiotics, we significantly will help to reduce the microbial resistance. So if we combine all the evidence, and the steering committee of EPOS 2020 devised integrated care pathways for all treatments. And here you see the integrated care pathway for acute rhinosinusitis. And all these integrated care pathways are built up the same way, with self-care and pharmacy here at the top, then primary care, and going down to secondary and tertiary care. Of course, here for acute rhinosinusitis, the main emphasis is on self-care, the pharmacy, and a little bit on primary care, and very few patients actually arrive in secondary and tertiary care. So if we look at the self-care, we see that we want to see the symptoms of acute rhinosinusitis, nasal obstruction, discharge, and facial pain or smell reduction. And then the first thing a patient can do himself, or the pharmacy, is to check for whether this is very serious acute bacterial rhinosinusitis. And I discussed the symptoms pointing at that with you. If that's not the case, patient can use self-care, decongestants, painkillers, herbal medicine, zinc, vitamin C, saline spray, and avoid antibiotics. You can find the evidence for all these medication in the EPOS guidelines. In the primary care, of course, again, it is checked whether it's acute bacterial rhinosinusitis, and then the primary care physician can see whether the patients are, whether the symptoms are there for more than 10 days or increase after 5 days, and give appropriate therapy, can consider to give an intranasal corticosteroids or decongestants, herbal medicine, and saline spray. Again, only in very few patients antibiotics are necessary. Only when the patients fulfill the criteria of acute bacterial rhinosinusitis, antibiotics can be considered. Patients are only referred to secondary and tertiary care when there is a risk or sign of complications, presence of alarm symptoms, symptoms that you can see here on the right, with orbital symptoms or very severe headache or frontal swelling or neurological signs. Or, for example, when the patient has an immunodeficiency. But most of the care, of course, is not given in secondary or tertiary care. Let's now have a short new look at the new classification, just to remind you, because it's such an important change in EPOS 2020, and it is really important in the decision of our management schemes. And tomorrow in the webinar, I will go more into how this classification can help you to manage your patients. So we divided chronic rhinosinusitis in primary and secondary chronic rhinosinusitis, in localized and diffuse, and type 2 and non-type 2. And the same for secondary CRS, like Professor Lund already showed you, with localized and diffuse disease and different examples of the phenotypes. If we now look at the evidence, you can find many of these tables and forest plots in EPOS. And this is just an example of what we show you. We asked ourselves a number of questions. So, for example, here were 2 questions. One was, is there evidence for the use of montelukast in diffuse bilateral chronic rhinosinusitis? And one was, is there evidence for the addition of montelukast to an intranasal steroid in the treatment of patients with diffuse bilateral chronic rhinosinusitis? And you can see the tables with the studies, 2 studies for one, 3 for the other. And the 2 we couldn't combine into a forest plot, but the 3 we could. So we could combine the evidence for whether there is an additive effect of montelukast on top of intranasal steroids in patients with bilateral diffuse chronic rhinosinusitis. And as you can see here in the forest plot, there was not. The 0 line was crossed. So no significant difference in adding montelukast to intranasal steroids in diffuse bilateral chronic rhinosinusitis. I give you a few examples. Of course, I can never show you all the evidence, but just to show you how we asked ourselves questions. So this, for example, is the forest plot answering the question, is it any use to give a higher dose of intranasal corticosteroids versus a regular dose in diffuse bilateral chronic rhinosinusitis? And yes, indeed, you can see that there is a significant difference between the patient receiving a normal dose and the patients receiving a higher dose. So the answer to the question was yes, it can be advantageous and effective to give a higher dose of intranasal steroids in patients with chronic rhinosinusitis. Here another question. Is it useful to operate patients, to give patients a FES to have a better entrance of intranasal corticosteroids in the sinuses? Are intranasal steroids more effective in patients that had surgery? And again, you can see the answer is yes. The risk ratio is 3 in the patient with sinus surgery and 2 in the patients without sinus surgery. So yes, sinus surgery is an effective way to improve the effect of intranasal corticosteroids. Here another example, aspirin treatment after desensitization in patients with NERD, so intolerance to NSAIDs or aspirin. And again, you can see there are 3 different studies. And when we combine these studies in a forest plot, you can see that there is a significant effect on the SNOT score on the top here and on symptoms on the bottom cartoon here. So yes, aspirin desensitization is effective in patients with NERD. We also asked ourselves a number of questions about the effect of surgery and tried to combine these as much as we could into systematic reviews and meta-analysis. Here you see the table, because it was not possible to do a meta-analysis of the effect of short-term antibiotics after endoscopic sinus surgery. And you can see here the results, and as you can see, there are 3 studies who showed no result and 1 study who showed a little bit of results. So in general, eyeballing these data, you could say there is probably no effect of short-term antibiotics after endoscopic sinus surgery, although I'm quite sure many of us still use that treatment, so it might not be effective. Also, the evidence about the surgery itself was evaluated. And here you see an example. We asked, is it useful to put the patient in reverse Trendelenburg position, so with the head up as much as possible to reduce blood loss during sinus surgery? And yes, you can see here that there were 3 questions that we could answer: the quality of the surgical field, the amount of blood loss, and the operation time were all favorably influenced by putting the head of the patient up as much as possible. So answer, yes, please put your patient in reverse Trendelenburg position with the head as high as possible to reduce blood loss and improve your quality of surgery. All the evidence that you can find in the 460 pages thick EPOS 2020 has been combined into integrated care pathways. And here you see the integrated care pathway for chronic rhinosinusitis. Again, as I said to you before, we have self-care, primary care, and then going down to hospital, secondary and tertiary care. Of course, the patient doesn't know all the things necessary to classify the disease into the classification that I showed you before. So patients only see their symptoms. And if they have symptoms, they can start with self-care, saline nasal spray, if needed, an intranasal corticosteroid, if that's available OTC in your country. Again, avoid antibiotics, but also avoid exacerbating factors like smoking or occupational exposure or allergen exposure. Patient can wait for 6 to 12 weeks whether that treatment is sufficient. And by the time they actually arrive in the primary care, they usually have symptoms for a few months, unless there are alarm symptoms, as you can see on the right in the pink cartoon here. In primary care, the caregiver will follow up with some more questions, especially about treatable traits, emphasize the importance of the proper use of intranasal steroids, educate the patient about compliance and the techniques, again emphasize the avoidance of antibiotics, and will check comorbidities like asthma. If again that is not sufficient, patient can be referred to secondary or tertiary care. And now we start to use our new classification, and we decide what sort of disease the patient actually has. Is there localized disease or diffuse bilateral disease? If there is a localized disease, we very often want to have a CT scan. Depending on whether there's suspicion of a tumor, that can be very urgent or not so urgent. then we can reject the diagnosis or confirm the diagnosis, and very often the treatment is surgically. But I will come to that tomorrow more extensively. It can be that we decide there is no CRS. The many patients we see with facial pain who do not have CRS, or the majority of our patients have diffuse bilateral chronic rhinosinusitis. So let's look at that part of this integrated care pathway now. Here you see that we directly, as soon as we see a patient with diffuse bilateral chronic rhinosinusitis, we're going to differentiate between primary and secondary CRS. If there's presence of bleeding, severe pain, tissue loss, signs of immunodeficiency, all that may point to a secondary diffuse chronic rhinosinusitis with a different approach. But most of our patients will have primary diffuse chronic rhinosinusitis. Now again, in secondary and tertiary care, we start with appropriate medical therapy. Again, nasal steroids, saline rinsing. Again, very important, educate the patient on the technique. Many patients use wrong technique, and the compliance, and how important it is to be compliant with the rinsing and the nasal steroids. And we can consider giving a short course of oral corticosteroids. We see whether that is sufficient for a period of 6 to 12 weeks. And if that's not sufficient, we do an additional workup with CT scan, allergy diagnosis, laboratory, eosinophils, for example, very important because it depicts the rest of our treatment. And we reconsider treatable traits and compliance. Now we want to know whether it is non-type 2 or type 2. And at the moment, the things that help us to point to a type 2 disease, as has been discussed by Professor Lund, is eosinophils in the blood, eosinophils in the nasal smear. You can take a biopsy to look at type 2 profile, although that is not always necessary. But also, for example, whether there is atopy, whether there's NERD, and whether there is a good reaction to systemic corticosteroids. All these aspects, and not to forget, a reduced sense of smell. All these aspects and the findings at nasal endoscopy of polyps and eosinophilic mucus all point to a type 2 form of disease. And now we're going to differentiate. For the patients with type 2 disease, we like to use systemic steroids or surgery. In the patient with non-type 2 disease, systemic steroids are usually not so effective. And here we can consider using long-term antibiotics or do surgery. Again, we check after a few months, and then there is a plethora of additional options, especially in the patients with non-type 2. And you can find all these, the evidence for all these treatment in EPOS. You can consider rinsing with xylitol, very effective in patients with biofilm, long-term antibiotics, although the evidence is still not fantastic, revision surgery, and of course, we can consider doing extra investigations to be sure that we didn't miss a secondary diffuse chronic rhinosinusitis. In patients with type 2 disease, additional treatment can be aspirin desensitization, a longer period of systemic steroids that we taper to the lowest dose where the patient remains controlled, revision surgery, and very important and new, and I will come to that tomorrow much more extensively, the use of biologicals. Since a few months in Europe, we have a half a year, we have the opportunity to describe biologicals for our patients with with chronic rhinosinusitis with nasal polyps. So the last few minutes, I would like to use to point a little bit at the options of biologicals. And here again, you see a cartoon of type 2 inflammation. I'm sure by now you know the most important cytokines are IL-5, IL-4, 13, and IgE. And all these cytokines now have biologicals to work against them. Mepolizumab and Reslizumab against IL-5, Dupilumab against IL-4 and IL-13, and Omalizumab against IgE. So here you see the effect of the biological that is available at this moment to prescribe in patients with chronic rhinosinusitis with nasal polyps, but the others will follow shortly. And you see here the effect of Dupilumab on the percentage of patients that improved with chronic rhinosinusitis with nasal polyps. And you see a significant effect of Dupilumab over placebo. Here, the same for the SNOT-22, a really impressive effect of about minus 30 points in the SNOT-22 total score. And these were in 2 studies. One was a study for 24 weeks, the other was a study for a year, and halfway the year they lowered the dose, but that didn't make any difference. And finally here, the impressive effect on the loss of smell. You see a significant reduction in loss of smell. So biological treatment will really change the way we treat our patients. And Euphoria, together with EPOS, came with indications for biological treatment of patients with chronic rhinosinusitis with nasal polyps. And you see here these criteria in patients who had sinus surgery. We realize that there will be exceptional patients who cannot have sinus surgery, but most patients will have had sinus surgery before they have this treatment. And you can see here the criteria: evidence of type 2 inflammation, need for systemic steroids or contraindication to systemic steroids, significantly impaired quality of life, significant loss of smell, and a diagnosis of comorbid asthma. And in EPOS, we now came with cutoff points. So you can see a SNOT-22 should be over 40. Patient should be anosmic on a smell test. In that way, we hope to help you and to guide you to choose the right patients for this new treatment. And that's important because the treatment of this at this moment is still very expensive. It's more than 10,000 euro per year. To come back to the scheme, biologicals can be put here in the additional therapy of patients with type 2 disease. Finally, EPOS 2020 also has a care pathway for pediatric chronic rhinosinusitis, and you can see the depicted scheme here. It is an extensive scheme. In short, you can say that intranasal corticosteroids, also in children, is the treatment of first choice. In second choice, in younger children, or in children with a low Lund-Mackay score, and adenoidectomy is probably the treatment of first choice. And in patients with a high Lund-Mackay score that do not react sufficiently to adenoidectomy and appropriate medical treatment, a FES can be considered. I hope you have the option to look at this whole scheme in more detail in the EPOS guidelines, and you can find the EPOS guidelines for free either on the Rhinology website, www.rhinology.com, or on the EPOS 2020 website. And with that, I would thank you for listening to this webinar. Goodbye.
Thank you very much for listening to this expose on EPOS 2020, and I hope it stimulates all of you to really read the document and to
come back tomorrow for the webinar. We got a number of questions from you, and I would like to answer some of them. There's a question from Israel asking on the role of sinus lavage in acute, I presume, bacterial rhinosinusitis and not giving antibiotics. There, unfortunately, is no evidence that sinus lavage is helpful. That doesn't say it's not helpful. We just do not have the evidence. There is evidence for giving antibiotics in real acute bacterial rhinosinusitis. So when patients really have the symptoms of high fever, severe facial pain, raised ESR, then there is a reason to give antibiotics. But there is no evidence, and that's new in EPOS 2020. We now evaluated all the evidence for post-viral rhinosinusitis, and in post-viral rhinosinusitis, there are a number of studies all showing no effect of antibiotics. So for the moment, we just do not have the evidence of doing sinus lavage, but we do have evidence to give antibiotics. There was another question: is there any evidence for different effectiveness of nasal steroids via drops, spray, or rinsing in primary diffuse chronic rhinosinusitis? You can find all these tables and the analysis in the EPOS document. There's one study comparing spray to rinsing, showing a better effect of rinsing. There's not a real good evidence that drops are better than spray. So we really need studies in that field, better comparing rinsing with drops, separately or nasal spray. So that's something for a new document. There is a question from Italy about long-term antibiotics, doxycycline versus macrolides. This is a very relevant and important question. We already discussed that for 10 years, I think more than 10 years now. There have been very few placebo-controlled trials with very different design, different dosage of steroids, making them quite difficult to compare. And although in a meta-analysis you put everything together, that might not be perfect in this case. One of the problems is to define what is clinically relevant improvement. For example, the doxycycline study that Ghent performed together with Amsterdam showed a minimal effect on nasal polyp size, but actually the clinical data were irrelevant. So doxycycline does not really have an impact on the symptoms of the patients, although the polyp became slightly smaller. 0.5 on both sides is not really a great effect. For the macrolides, there is a large study going on at the moment in the UK called MACRO that will look in a large group of patients what the effect of macrolides are in chronic rhinosinusitis. So I hope that in the near future we can update those data with better studies, helping us to really understand the exact role of macrolides in the disease. There was a question, can you explain what you said regarding the number of sinuses with mucosal thickening that's considered a sinusitis? I think that was something from the lecture of Professor Lund, so I'll give the word to her to explain that a little bit more. Valerie, please.
Okay, so I think the questioner might be referring to the slide I showed on clinical definitions, where I talked about the use of endoscopy and CT in order to make the definition or confirm it. What we said was that you had to see some mucosal change in the osteomeatal complex and or sinuses. But the caveat was that if there was just minimal thickening, in one or two walls of a sinus, so say the maxillary, sphenoid, or frontal sinus, for example. But in the case of the maxillary sinus, it did not include the osteomeatal complex or the ostia of the other sinuses. Then it was unlikely to be rhinosinusitis, possibly allergy or the tail end of a virus or something like that. I think that's what the questioner was referring to. So just minimal change that doesn't involve the ONC isn't necessarily confirmation of rhinosinusitis.
Then there is a question, very nice question. Why do you talk about non-type 2 and not call it type 1? There have been a number of cluster analyses on the inflammatory pattern in chronic rhinosinusitis, showing that apart from type 2, there are many other forms of inflammation. You can have an IL-17 dominated inflammation or IL-22 dominated inflammation. So definitely not all type 2 are actually type 1. So for that reason, we decided to discriminate between type 2, which is relatively easy to determine in daily clinical work, and the rest, where we fully appreciate that that's a combination of a number of different inflammatory patterns, but we are still not so good in discriminating these different forms of inflammation in our daily work. We can do it in a very complicated cluster analysis, but that's of course of no use in our daily work. So that's the reason for type 2 versus non-type 2. There is a question, at which age FES is considered if pediatric patients do not respond to other treatments. I think the steering group did not fully agree on that point. Let's first say there's no hard evidence. So there seems to be a little bit of discrepancy between the European point of view and the American point of view. Most studies, good studies done with FES in very young children are all done in the States and only by a few authors. In Europe, I think most authors feel that they're very seldomly needed to do a FES in a child under the age of 10. Very, very exceptional cases of severe blocking polyps in cystic fibrosis, or children with PCD with real problems or immunodeficiencies. But in general, children with chronic rhinosinusitis do not need FES, in my opinion. But as I said, that is not everybody agrees on that, and we just do not have the data. So in this cartoon, we didn't put a real sort of age limit, but said in younger children versus older children, which is of course very it is disputable what the exact age is, and we just do not know that. There are many questions coming in, and I'm sure we can't answer them all, but I'll try to answer one more. There is a question about the role of short course of oral corticosteroids in acute rhinosinusitis. There are 2 or 3 studies all showing that oral steroids in acute rhinosinusitis reduces severe pain by about half a day. Well, we could argue that half a day is not a massive improvement, and on the other hand, you give steroids which would potentially reduce the immunity of the person in an acute situation. But it seems that there is a reduction in symptoms, and you have to balance that potential advantage to the disadvantage of giving an oral steroid in acute bacterial rhinosinusitis. We have time for it. That's wonderful. We have time for 5 more minutes, so I will go on and hand the next one to Professor Loons to let her do some work. And the question is, thanks for the presentation. How best to treat acute fungal rhinosinusitis within the new EPOS 2020? Valerie, would you like to answer that one, please?
Well, it's an excellent question and quite a sort of complex one in the sense that we are actually going to have some discussion later on in the seminar on, I think, Wednesday about some of these other conditions. But I think the essence here is looking at the evidence, and it hasn't really changed notably since 2012. What doesn't work, we can say, are the use of topical lavages or rinses with an antifungal. This is something which was, quite an important finding, a negative finding, if you like, in a number of studies. And since then, there have been others that have confirmed that. Lavage, on the other hand, with saline is helpful. Steroids, both topical and oral, are helpful. But the use of actual antifungals, paradoxically perhaps, are not as helpful as we would have thought them to be. And that's really the pith of the various forest plots and tables within the section. But if you look at EPOS, and I'd like to emphasize again that you can access these documents free of charge, just download them off the Rhinology website. They're there, both the full document and the executive summary. To anybody who wants to go there, then you can see all of this information there. And it's all available for anybody who wants to see it.
Thank you very much for this extensive answer. There's a question from Egypt about the use of high volume, high dose Pulmicort nasal rinsing. Well, as I said before, although many of us feel that nasal rinsing with high dose steroids is more effective than nasal spray or nasal drops, actually the evidence is really, really limited to the one study from Richard Harvey comparing mometasone nasal wash to nasal spray. But whether putting Pulmicort in a nasal wash or just dripping it right in the nose, we just don't have the evidence to show that one is better than the other, and we need studies to actually do that. There is a question on, is there any role of immunotherapy in patients with chronic rhinosinusitis with underlying allergic rhinitis? Again, a question from Malaysia, again, a very difficult question to answer. The data on immunotherapy are very limited, and it seems that there, of course, if the patient, it's very difficult to discriminate the symptoms of allergic rhinitis with the symptoms of chronic rhinosinusitis. It's relatively easy when it's a seasonal form of allergic rhinitis, where the patient can easily say, well, now it's my tree pollen allergy or my grass pollen allergy. But in some situations, if patients have symptoms year long, for example, due to house dust mite, it can be very difficult to discriminate from chronic rhinosinusitis. There is some data that in allergic, in patients with allergic rhinitis and chronic rhinosinusitis, that the immunotherapy reduces the total amount of symptoms. Whether that is really reducing the chronic rhinosinusitis or just the allergic rhinitis symptoms is not clear at the moment. That has to be the last question. I thank you all for all the very interesting questions, and you see that even with the document of 460 pages, there is still a lot to ask, and that is one of the reasons why we want to go on with these Delphi questionnaires, and in the near future we will set that up to try to answer all questions where we do not have sufficient evidence to with a group of experts to come to the best possible advice based on all our experience at the moment. So look at rhinology once in a while, and we will come up with that in the next period. Valerie, I give the word to you to close this session, and I would thank everybody looking and hope you'll all be back tomorrow to talk again.
Thank you very much, Vitske. And again, thank you very much to you all giving up time in these difficult circumstances to listen, and for your really interesting questions. The questions always expose things that, we don't always know the answers to, and we're happy to look at. This session actually will be streamed again this afternoon. If you missed some of it, Professor Kern will actually be moderating that, but our lectures will be given again. And otherwise, we look forward to seeing you all again tomorrow morning with same place, same time, but something a little bit different on EPOS 2020. Thank you very much indeed. Bye.
Bye-bye.